All right, welcome everybody. I'm Sandrine van Schaik, Vice Chair for Education in the Department of Pediatrics. I believe Dr. Hirsch is not around today, so I will welcome everybody. Also do our land acknowledgement, which has become a tradition in Grand Rounds to really make sure that we remember that we're on the land of the Ramaytush Ohlone people, who are the traditional custodians of this land. And I find this land acknowledgement, I always want to sort of say, we start doing it, but I don't want it to just be a checkbox. I actually really want us to think this is where we come together as a community and really reflect on how we as a community can become better and grow in the various ways that we as pediatricians and pediatric providers contribute to the mission of UCSF and healthcare in general. And I really think sort of thinking about the traditions of the Ramaytush Ohlone community and having productive conversations and educating ourselves is a good way to bring attention to that with a acknowledgement like this. It is my great honor and pleasure to welcome our speaker for today, who's someone who has been at UCSF for a long time. I've been at UCSF for a long time, and we've never met until just now. And that's because we do not consult a lot of mental health providers for a diagnosis of ADHD in the PICU, but maybe we should. Professor Newmark is a clinical professor in our department. He also is a professor in the Osher Center for Integrative Medicine and the head of Pediatric Integrative Neurodevelopmental Program at the Osher Center. He specializes in the treatment of autism, ADHD, and other developmental or chronic childhood conditions. He did both his medical school and residency at the University of Arizona and went on to do a 2-year integrative medicine fellowship at the Arizona Center for Integrative Medicine. He also has a long-standing interest and expertise in nutrition and its impact on childhood development and general health. And he combines conventional medicine with nutrition, behavior management, and various complementary modalities. He has lectured widely on both autism and ADHD and has authored 3 chapters in integrative medicine textbooks. He has written a book entitled ADHD Without Drugs, A Guide to the Natural Care of Children with ADHD. And his UCTV talk on ADHD has had over 4.6 million views. And I'm really excited to hear what's new and in the field of ADHD. I'm going to completely date myself. When I was a medical student back in the Netherlands many, many years ago, I actually once organized a journal club discussion reviewing the literature on what we then called minimal brain disorder, and whether that was really a disorder or just a societal way of labeling kids that were just a little bit more active than anybody else. So we've come quite a long way since then, and I am really excited to hear what Professor Newmark is going to tell us today. Welcome.
Okay, thank you for that nice introduction. Thank you for inviting me, and thank you all for coming. You know, I do a lot of lectures, but almost all of them are online now. And it is such a pleasure to actually be talking to real people, assuming you're not like all AI projections or something. It's really nice. So I want to start with making sure we're all online or all together about what the definition of ADHD is. It's pretty simple. This is from the DSM-5. Neurodevelopmental syndrome, difficulties with attention, impulsivity, and hyperactivity. And they have to cause, symptoms have to cause a significant impact on a child's life to be diagnosable as ADHD. And that's really important to keep in mind. This has a strong genetic component, but also many environmental influences. It's also, in my opinion, important to realize that it's a contextual syndrome, because the same set of behaviors that a child has can be seen by a family, parents, teachers as normal or as indicating ADHD and causing a problem. There's only usually complete agreement at the extremes. The other part about ADHD is that everything about ADHD describes a range of normal. So hyperactivity. Some people are quiet, some people are active, some people are very focused, and some people are distractible, some people are careful, and some people are impulsive. And where that becomes like too active a person becomes ADHD or active, distractible, and impulsive is very different in different contexts. So, we really wouldn't want an entire population of extremely quiet, focused, careful people. We'd never have any art or other creative endeavors. So I don't think it's a surprise to you all that the rate of ADHD diagnosis has increased absolutely dramatically in the last, 50 years now, since 1970, which you were just hearing about, up to 6 million children now. Here's just the last few years, which are on another graph. It looks like it's kind of steadied out at least. But if you look at really careful epidemiological studies done by people in the field, almost always the percentage of people with ADHD, the prevalence is 3 to 5%. In the United States, the prevalence is 9.8%. So that's 2 to 3 times as many as really should be diagnosed. Here's psychostimulant use in the US, again, going up very, very quickly, even more quickly than the diagnosis, which is what you would expect. The rate of psychostimulant use given ADHD usually hangs around 60% in most studies. Here's an interesting one, psychostimulant use by country. So up here is us. Up here is Medicaid patients, and we'll get, in the United States, we'll get to that. And down here is almost the entire rest of the developed world. This one is Iceland. I'm not sure why that is, but there you have it. Another thing about ADHD in the United States is the dramatic differences in prevalence in different parts of the country. The dark is the highest level, over 11.7%. And as you can see, there's a huge concentration in the Southeast, going up to the Mid-Atlantic, or this northern part of the Atlantic states. And those can definitely be seen to be related to poverty. These are among the lowest socioeconomic status states, but it's not all like that. Up there in up here, there's New Hampshire and Maine, and New Hampshire is one of the wealthiest states, and Maine is kind of in the middle. So it can't all be explained by socioeconomic status. And as you can see, there's really, really dramatic differences. And in fact, if you go by county, some counties have a 20% rate of ADHD prevalence, which is really remarkable. So what about poverty and race? In general, overall, lower income families are much more likely to be diagnosed with ADHD. That's for sure. The rest of it is a little tricky depending on what studies you look at. Given low socioeconomic status, Black and white people have similar rates of ADHD diagnosis, while Hispanic people have a significantly lower rate. Also, some studies show that Black children have higher rates of actual symptoms, but lower rates of diagnosis. And the other thing that is clear, and I know you've heard a lot about ACEs in your lectures, that increased number of ACEs is correlated with increased ADHD. And this is kind of just a schematic of how it looks. Low socioeconomic status is associated with prenatal stress, which on its own increases the risk of ADHD. Poor nutrition, ACEs, as I mentioned, family stress, poor schools, toxic exposures, violent neighborhoods. And the thing is, it's sort of a double whammy because all these things can create children who have ADHD symptoms, but then they're thrown into schools and lifestyles that tend to decrease their chances of getting good care, of getting the kind of help, tutoring, special classes, IEPs that people are likely to get in better schools. So it actually increases the risk of diagnosis, even given a certain set of symptoms. So it's kind of a double whammy. So we have this huge increase in prevalence. So what is going on? Are there more kids with ADHD, or are we just diagnosing it more? So there's a couple of possibilities. One is there's always been this many kids with ADHD and we've just missed them. Another is we're misdiagnosing people. And finally, maybe there's more people who actually have ADHD. So this first one, I think this is absolutely true. Back in the 70s, a lot of these kids with ADHD were termed lazy, stupid, class clowns, ignored, left back, punished. And then there's actually, we're finding out back then, there were lots of people with just the inattention subtype of ADHD, who mostly were girls, but not only, who just sat there very quietly, didn't cause any trouble, and didn't learn anything. And they were just sort of passed from grade to grade. So it's great that we're finding these kids and doing what we can to help them. Number two, we're misdiagnosing kids and adults. I think the biggest reason for that is the lack of time for adequate evaluations. There takes time, and I'll go over this a little later, to really diagnose ADHD in an accurate way. And we have schools and parents absolutely demanding treatment. We have parents who have less time to support kids who may have higher needs. We have a society with a very small safety net in terms of parental leave, in terms of healthcare. All those things lead to a decreased ability for parents to work with kids. And also, let's face it, we're a pharmaceutical society. In this country, we'd really prefer to solve a problem with a pill rather than anything else. It may or may not be a coincidence that we're one of only 2 countries in the entire world that allow pharmaceutical advertising. So us and New Zealand. And as you can see, the sales of stimulants have actually risen even faster than the rate of ADHD. So there's a lot of things that can be misdiagnosed as ADHD, or even more comorbid with ADHD. So you have ADHD, but you have this other problem. Depression or bipolar. Anxiety is a big one. I can't tell you how many of my ADHD kids have anxiety. I think you've probably all heard that anxiety is going up dramatically just in the general pediatric population. But the kids I see so often have anxiety with their ADHD. And often the anxiety is more of a problem for them than the ADHD. And I'll ask the kids, I'll say on a scale of 0 to 10, how bad a problem is your ADHD? 4 or 5. How bad a problem is your anxiety? 8, 9. So they really need to take the time to find out about that. Learning disabilities are another big one. If a child has ADHD and is not doing well in school, especially like reading, or especially if reading is bad and math is good, you really need to make sure they're evaluated for learning disabilities, dyslexia, dyscalculia, those kind of things. Gifted children can get bored, obviously witnessing sexual or physical violence. Sleep apnea is something important to look for. So what's the ADHD evaluation like? Well, as in most things with pediatrics, it's history, history, history. There's actually no lab work, no test, no computerized test of attention that on its own can diagnose ADHD. We do use some type of standardized questionnaire. It's important, if you can, to speak to teachers, counselors, or school psychologists and review anything that's been done as far as workup before. But here's the question: who has time to do this? If you're a family practice doctor or a pediatrician, it's very unlikely you'll have time to do this well. I'm extremely fortunate working at the Ocean Center. We have more time. Developmental pediatricians generally have the time, but nobody can get in to see them because they're so busy. So it's really a problem for those people seeing kids in a primary care practice to do this well. How about if you just use the Conners? So this was an interesting study that was done. They took 279 children and they gave them the gold standard evaluation. They had a psychologist interview. They had somebody observe in the schools. They did a full history and physicals, about as good a job as you could do. And then they used that as the gold standard and compared it to what happened if you just got a Connors. And that was the Connors long form, which is like more inclusive than the Vanderbilt or the Connors short form that you're probably using. And the sensitivity was pretty good, 83%, not bad, but the specificity was 35%. So that means if you were to just use the Connors, 2/3 of the kids you thought had ADHD would not have ADHD by a gold standard. So that's something to really think about. Now, to be fair, nobody just uses the Connors without saying a word to the parents. I mean, that would be weird, but still, I think it's important to keep in mind this is not a specific instrument. Well, aside from that misdiagnosis, what if there's more children that have ADHD? And I think this is really happening. It's genetic and environmental. The genes haven't changed, but the environment has. There's increased prenatal, childhood, and environmental stress. There's many research studies correlating increased parental stress, prenatal stress with ADHD. There's increased demand from schools. Schools are asking more. There's environmental toxins in the prenatal and early childhood environment. Screen time is a big issue, and poor nutrition. I think all of these can be combining to actually increase the amount of ADHD. And I'll show you some of this. One example of the demand on kids that's increased is kindergarten. Between 98 and 2010, 12 years, we went from 30% of kids kindergartens expecting to teach kids to read to 80%. Kindergarten has changed completely. And most kids can still do it. I mean, most kids can learn to read in kindergarten. They can learn to sit still. But the fact of the matter is there's certain kids who can't. And it's not because they have ADHD. They're just not developmentally ready. And, should kids who are 5 years old be expected to sit at a desk for much of the day and do work? But if they don't, I see a lot of those kids being brought in for ADHD evaluations. Here's another one. If a child was born in August, they were more than twice as likely to be diagnosed with ADHD and treated with stimulants as if they were born in September. Why is that? Because they're the younger kids in the class. This study has been repeated in Canada, in Iceland, again in America, and every time it comes out the same. Kids who are younger in the class are being diagnosed with ADHD way more quickly. I think that's an overdiagnosis. How about pesticides? There's many studies correlating pesticide exposure and ADHD. I don't have time to go over all of them, but in this one, 1,139 children were checked. They looked at the amount of pesticides in their urine. And children with the highest level of the most common pesticide, higher than the median, were twice as likely to be diagnosed with ADHD. So pesticide exposure either worsens ADHD or it contributes to the development of ADHD. We don't know which, at least from that study. And I wanted to show you this slide again, because I think if you're over here, pesticides are probably not going to make you have ADHD if you're really quiet, careful. If you're over here in the risk group, if you're sort of active and distractible and impulsive, that may be where pesticides take you over the edge. I think there's kids who would be okay if they didn't have other environmental factors that were causing the problem. By the way, this is just an aside. Eating organic actually helps. In this study, they just for a few weeks, they gave kids fruits and vegetables, not even their meat, that were organic. And they had an 80% drop in the amount of pesticides they found in their urine. So that can be done. I know for a lot of our patients, that's a hard thing. It's expensive. But now Walmart has organics, Safeway has organics, Costco has organics at pretty reasonable prices, not much more than the others. So it's something you can at least suggest to most of your families. How about screen time? I mean, it's hard to know what to say about screen time. It's a nightmare. It's a nightmare for my families trying to control it. They have kids who are on screens literally all day long. And now that schoolwork is on screens, that's just, it's like just made it so much worse. Because not only are the kids spending time doing schoolwork on their screens, but you can't stop them from going to TikTok or YouTube or playing video games when they're supposed to be doing their homework unless you're standing there right above them. So it's a huge problem. There's many studies correlating increased screen time with increased ADHD, but they are correlations. It could be that kids with ADHD tend to spend more time on screens. But I did want to show you one longitudinal study. This is from Canada. So in this study, they looked at screen time in 2,200 3 and 5-year-olds. The mean screen time at 3 years old was 1.5 hours and 1.4 hours at 4 years old, presumably because they started going to preschool more. Then they compared the kids who had that much screen time to kids with less than 30 minutes a day. Kids with more than 2 hours of screen time had almost an 8 times a risk of meeting criteria for ADHD, and of 5 to 9 times as much risk as having significant attention problems. So this tells me that screen time may be really increasing, setting up kids for having ADHD. As an aside, another thing that's really important for kids' social development, which is really a problem in ADHD, is play, unstructured play. And this is something that is, at least in this society, especially in the Bay Area, is ceasing to exist for various reasons. It's where kids learn rules. It's where they learn to make rules, figure out rules for behavior, figure out how to interact. It's not the same as going out and being in soccer practice or chess club or martial arts, all of which are great, but they're all controlled by adults. They're all listening to instructions, and they don't get that time for play. And it's really a hard problem, and I think contributes to ADHD. So there's more ADHD. There's lots of it out there. Some of it's real, some of it may be overdiagnosed. But do all kids with ADHD need psychostimulants? So here's my little talk about that. So the question is not stimulants versus integrative medicine. I think an integrative approach is worthwhile whether or not medications are used. And I'll be talking about the integrative approach. I can believe in some kids it can prevent the need for using psychostimulants. And also, I think it's important to look at, because I don't think we know enough about the possible negative developmental effects of 10, 12, 15 years of taking these very powerful drugs. So why not just use them? They work, right? Well, yeah, they do, about 70% of the time. And I have many kids in my practice using these medications. They can improve school, home, family life, social success. They're an important tool. But they can have side effects, and the long-term efficacy is not completely clear. There's also, as I said, not good research addressing the effect of these medications on the developing brain. So here's some of the side effects we see. I think you're probably familiar with a lot of them. Decreased appetite and weight loss, trouble sleeping, abdominal pain, headaches, tics, about a 1 in 100, 2 in 100, bizarre behavior, hallucinations. At least 1% of kids have hallucinations, and they're not pleasant. Usually they're bugs, all around their head or things like that. And I see this regularly. But there's a more subtle stuff, and I see a lot of this, and that's maybe because of my practice. I either see kids who don't want to use medications or kids who've tried medications and had negative effects. But these are the things you see, a kind of dampening of the personality. Kids will tell you who take it and don't like it, will tell you they're bored. They'll tell you they can't talk to their friends like they used to. So it's something you need to watch for, and it's common. So if anybody is interested in the long-term efficacy debate, there are people who think that there's good evidence that psychostimulants are effective in the long run, and there's people who don't. If you're interested, I really recommend this volume, and you can see the arguments for and against with all the references. It would take too long to go into. I would say that the question is still not well answered. That's important because a lot of times these kids get on psychostimulants at 6 or 7 or 8, and they're on them till they're 18, 20, 21, and longer. This is a very interesting study. So they took some kids who had ADHD and were taking a psychostimulant. And they did a summer program. So for 3 weeks, they were in class all morning, and they were either taking Ritalin or a placebo. And then the next weeks they switched, and they were in class all morning, but they were the other people took Ritalin or a placebo. And across the board, by teacher ratings, their ability to finish work and their behavior improved dramatically when they were taking the Ritalin and not the placebo. It was very clear. However, when they tested the kids on the material, the kids who were, while they were taking Ritalin during that 3 weeks, didn't learn any better, didn't have any better grasp of the material than the kids who were on placebo, which is kind of shocking. I mean, you would think if they're paying attention and they're finishing their work, they would learn it better. But in this study, they didn't. Now, I don't want to make too much of it. It's kind of a small study. It's just a few weeks, just a few kids, but it is food for thought. And one of the things it shows, and this is true of a lot of kids in my practice, some kids with ADHD can absolutely look like they're paying no attention whatsoever, can refuse to finish their work, and at the end of the test, they get perfect grades. Or when they do their standardized test, they get perfect grades. So just not seeming to pay attention does not mean they're not learning. So what's an integrative approach to ADHD look like? So there's nutrition, the basic principles of nutrition, the idea of food sensitivities, and then a certain set of supplements, botanical supplements, looking at sleep, parenting skills, behavior, school interventions, and you can see the rest, and we'll go through these. There's also alternative medical systems, which you probably have heard of. A traditional Chinese medicine, acupuncture, and herbs is the one that actually has a lot of research on it, mostly coming out of China for the improvement of ADHD. So I'm fortunate to have a wonderful TCM doctor at Osher who works with kids, and so I will make that referral. The other things I don't use, I don't know well enough, and I'm not aware of much research about. So what about food sensitivities? The idea is that kids with ADHD can be sensitive to certain foods, and those foods don't cause GI symptoms necessarily, but they affect behavior, they affect ADHD symptoms. Usually they're not allergic by IgE testing. So in this Inca study, they took 100 kids, they put them on a very restricted diet, as you can see, a really restricted diet, for 5 weeks. And as you can see, 64% of the children had a very significant improvement on their ADHD rating scales. Now, this was not blinded for parents and teachers, although the assessor was blinded. So they went ahead and did a second phase where they gave the kids challenge foods, and 19 of the kids relapsed. They went back to where they'd been. So that's a pretty good study in the Lancet, right? But it's only one study, wouldn't make too much of it. But they've been doing the same study since the 1980s. 1980s, 76 on an oligo-antigenic diet, few foods, 62 improved. Double-blind test, positive. In 2000, did I do that? Okay. In 2012, 59 of 78 improved. So this study has been done a number of times. Dr. Nig, who is an expert in this area, did a meta-analysis of all of the studies involved with food elimination diets, and felt that probably 35% of children would respond, which is kind of what I see. I usually tell people a third. And that's a pretty significant amount of children you can help just by removing a food from the diet. I use a multiple food elimination diet. I do it for 3 weeks. And then if there's no change, tell the parents to go back to their usual diet. If there is a change, what I do is I have them add foods one by one and see what the precipitating factor is. By far, the most common are gluten and dairy, but it could be corn, soy, eggs. And then artificial colors and flavors and preservatives. We know these cause hyperactivity. In this study, they caused hyperactivity in everybody, not just people with ADHD. And my parents tell me this all the time. If they get red food dye, they're gone. And that's what's caused a lot of the confusion about how much sugar plays a part. I don't think sugar is great for anybody, but the acute effects are often thought to be sugar when it's a candy bar that has artificial colors, or Gatorade. Think about all the things that have it. Gatorade, the Cheetos, and the hot chips, all kinds of stuff has artificial colors. In Europe, 14 years ago, they put a warning label on foods with artificial colors because they knew that was happening. And a really interesting thing, Kraft macaroni and cheese has a yellow color. And once this warning label went up, they found a way to use just a natural color in their macaroni and cheese in Europe, but kept the artificial color here until just a few years ago. And now in California, we're actually banning some of these. This is a very new law, just passed in the fall. And they're actually banned, it's not a warning, they banned 4 common food additives. How about basic nutrition? Well, I think the sad American diet is a big problem for kids with ADHD. High in carbs, sugar, unhealthy fats, low in fiber. And this is a big problem in my patients. Now, Pop-Tarts is, it sounds like kind of a joke, although a lot of kids do have Pop-Tarts for breakfast. But what about frozen waffles? Frozen waffles with syrup, really common breakfast. Well, what's a frozen waffle? A frozen waffle is highly processed flour. And then you give it to the child and pour a bunch of maple syrup on it, or jelly or something. And now you have basically sugar upon sugar with no fiber, no protein, and very little fat to help in the digestion. You might as well take a funnel and pour about 15 teaspoons of sugar right down their throat and send them off to school, because that's the effect. So I talk to my parents a lot about breakfast. And where that might be important is that there's evidence that now that the microbiome, which we now know is important in just about everything, is important in ADHD. I do a lot of work with autism, and the evidence is overwhelming that the microbiome plays a big part. But it's increasing evidence now that the microbiome may play a big part in ADHD. And if that's true, these kind of diets are very bad for the microbiome. The microbiome feeds on healthy foods, fiber, fermented foods. And so that may be the mechanism, or one of the mechanisms by which that works. The other mechanism is the glycemic index. So when you give kids these kind of breakfasts, their blood sugar goes up, they get an insulin reaction, their blood sugar goes way down, and now they're irritable and jittery right around 9 or 10 o'clock in school. In this study, they actually showed that a low glycemic breakfast improved executive function, working memory, and attention, better than no breakfast or a high glycemic breakfast. There's been some other interesting studies. They did a 12-week randomized, blinded trial of the DASH diet, and they showed significant improvement in ADHD symptoms. Obviously, the parents and children knew they were on the diet, but the teachers were blinded, and the teachers' ratings improved significantly. Then a correlational study done in Spain, they just looked at kids' diets and saw how adherent they were to the traditional Mediterranean diet. And those who were with the lowest adherence had 3 times the risk of ADHD. So I think diet is really, really important. I work with that. I have handouts I give the parents, which I'll be happy to share, by the way, about an optimal diet for ADHD, which is pretty much an optimal diet for anybody, any kid. So here I want to tell you a little bit of a story rather than a study. There was a place in Wisconsin called Appleton Central High School. This was a school where they sent the most difficult kids, not just kids with ADHD, but kids who were disruptive, truant, emotional problems, dysfunctional home environments, really difficult school. And they did one intervention. They set up a healthful meal program for the cafeteria, and that included breakfast as well as lunch, fortunately. And they removed all the junk from the vending machines. Okay. The difference was dramatic. I can say without hesitation that it's changed my job as a principal, just this intervention. And you can see the quote of all the changes that happened. Teachers, I've noticed enormous difference in the behavior of my students in the classroom. Just a single dietary intervention with the most difficult kids. Okay, so that's diet. Now some of the nutritional supplements that I use a lot. So we have omega-3 fatty acids, which usually is in the form of fish oil. As you probably all know, omega-3 fatty acids are very, very important for normal brain function. Almost everybody in this country who doesn't eat fish, which most kids don't, or who don't take fish oil are relatively low in omega-3s to omega-6s. And children with ADHD indeed have decreased levels of O3 in their red blood cells and plasma. And we know that O3 supplementation increases these levels. And most research, including several meta-analyses, support the efficacy of omega-3s for ADHD. In this particular meta-analysis, they summed it all up and they felt that fish oil was about 40% as effective as stimulants. That was pretty dramatic. I mean, for something that's generally healthy, not very expensive usually, and has very few side effects. So I use it, I pretty much use it in all of my kids with ADHD. For a while, I've been getting, you can get omega-3 fatty acid levels from Quest or even from Oakland Children's, but not from the UCSF lab for some reason. And almost every child who I check who doesn't take omega-3s, it's low. There's some unanswered questions about fish oil. How much do you give? And this is a big one. This is how much I give. If anybody's worried about the amount, there's 1,800 milligrams of EPA and DHA just in 3.5 ounces of salmon. So when I'm treating with this kind of amount, it's really not all that much. If a kid does eat fish, I'll say, well, don't take your fish oil on the day that you eat fish. It's fine. How you're getting kids to take it is tricky sometimes. Obviously, they're not going to take those gigantic fish oil pills. There are smaller ones available now. There's liquid. And I spent years saying how not to use gummies because they hardly had any EPA and DHA in them, but now they do. Now there's a product that has 1,000 milligrams EPA plus DHA in 2 gummies with very little sugar. I won't say the name because I'm not supposed to do that, but you'll be able to figure it out. So fish oil. Something that's maybe less well known is that low ferritin, iron deficiency, is highly correlated with ADHD. So you can see from this study, kids with ADHD had half the level of iron, of ferritin, as controls. And they were not anemic. Their hematocrit, hemoglobin, and serum iron were all normal. And this was confirmed by a meta-analysis of 11 studies. And the interesting thing is why? Why would kids with ADHD have low ferritins? And I certainly don't know the answer, but I'm wondering if it comes back to the microbiome and poor iron absorption again, because that could be. So this study showed that iron supplementation actually improved ADHD, randomized double-blind study. And the thing about iron is ferritin is iron is an important cofactor in dopamine production. And dopamine is the way that for instance, psychostimulants work in the frontal lobe. As psychostimulants increase dopamine production in the frontal lobe. Well, if you're low in iron, you may not be able to respond as well, or you may not be making enough dopamine at all. There was another similar study in 2021. So I use 30 to 40 milligrams of iron if kids are not anemic. And as you know, that's a pretty low dose. The dose for anemia is 3 to 5 milligrams per kilogram. And with the iron I use a chelated iron, I get constipation or stomach aches in less than 10% of my patients. Zinc is also an important cofactor. A lot of the studies show zinc to be important, but mostly when zinc is deficient. And so I check zinc in most of my patients, and I'm surprised maybe a quarter of the kids I check have true zinc deficiency. So, and of course, if we never check, we're never going to know. In this study, they actually showed that if somebody was taking amphetamine like Adderall, giving zinc lowered the amount they needed for optimal effect by almost 40%. So you can use these together. And I think that's all true, by the way. Even when I have kids on psychostimulants, I won't stop giving them fish oil or iron if they need it, or zinc if they need it, just because we started medication. There are some botanicals with research for ADHD. It's usually not a lot of research, just a couple of few studies. I use them somewhat regularly: ginkgo, saffron, surprisingly, and bacopa, which is an Ayurvedic herb. And all of them can be helpful. They're certainly not dramatic. Actually, none of those interventions I've mentioned are dramatic. They often take a few months to take effect. And then behavioral management is really, really important. Getting away from nutrition and supplements. These kids often, especially not the inattentive types, but the kids who are hyperactive and then often oppositional, can be very, very difficult. They're impulsive, they're oppositional, they argue, it's hard to rein them in. And parents often end up feeling guilty, angry, confused. Maybe the way they raised their first kid isn't working. Maybe the way their friends are raising their kids isn't working. And they end up with these maladaptive patterns where they're either yelling at their kid or just giving up. And either one is really bad. So I think helping parents with this is really crucial. It can make a dramatic difference in kids' behavior. There's lots of parenting approaches. We do some here at the health clinic. I like one called the nurtured heart approach, which I'll talk about. But the important thing is to give them a significant approach. And often mental health consultation is really helpful for the parents. Give them guidance. So I spent most of my career in Tucson. And there was a school called Tilson School, which was in the underserved part of town. It was a failing school, which meant the state was considering taking over and changing things. And the principal heard about this one parenting approach called the nurtured heart approach. And she instituted this approach in the whole school. Teachers, parents, janitors, anybody who worked in that school had to be using this approach, trained everybody. And the results were absolutely dramatic. Discipline problems dropped, special education referrals dropped, psychostimulant use dropped. And at the same time, it became a performing plus school, which in Arizona is a big deal. It means way better test scores. Just from a behavioral method and not even being given at home, just at the school. I talked to the principal who I knew, and she said people were moving from the wealthy part of town to her district just to get their kids into this school because it was doing so well. So I think probably you know about this, but it's really important to make sure the school interventions are taking place. Kids with ADHD are generally eligible for a 504 plan, which has these kinds of modifications and many more. Sometimes they're eligible for an IEP if they have dyslexia. So one of the things that you need to look at is the fit that the teacher and the child. Sometimes I get these kids who did great in one grade and bad the next grade and great the next year. And it all has to do with teacher fit, not necessarily good or bad teachers, but how that teacher relates to the particular child. Sometimes you can't do anything about that, but it's good to keep in mind. Cognitive behavioral therapy has good evidence for efficacy in ADHD in adolescents and adults, 12 years old and above. In one study, they randomized people to either get CBT and dextroamphetamine or CBT and placebo. Both groups improved, but the medication group didn't improve any more than the placebo group. 6 to 12 sessions can be effective. It doesn't have to be, years-long therapy, so that makes it easier. There's some computerized brain training that's really interesting. So the first one is EEG neurofeedback. This has been around for at least 20 years. And the idea is that kids with ADHD have abnormal brainwave patterns, which they do. They tend to have not enough beta waves, which are your focusing waves, too much theta waves, which are your sleeping waves, relaxing waves. And using a biofeedback mechanism, kids can actually change their brainwave pattern. There's been a lot of research about this, almost all of it positive. The problem is it's really expensive and time consuming. Usually you're talking, it's 3 to 40, it's 30 to 40 sessions. And, you're talking $4,000 to $6,000. And in my patients, the results have been variable. It's definitely not a predictable game changer. So that's a lot of money for something like that. There's a new thing on the horizon. No, it's not on the horizon. It's here anymore. It's called Endeavor. It's a video brain training program, which is now approved by the FDA because randomized studies were done and showed that it was helpful. And this one, a child just simply plays this video game at home, 30 minutes a day, 5 days a week for 3 months. And that's what's demonstrated the positive effect. This was actually developed here at UCSF's neuroscience lab with Dr. Gazzelli, in part. That is only $100 a month for 3 months, so it's obviously way, way, way cheaper. So far, some of the kids who I've recommended it to really see good results. Some kids don't. The kids can get bored because it is the same game. The way it works is that while they're playing, the information is being fed into a central computer, and then the game is being changed as they play. So it keeps up the exact right amount of challenge for the particular kid. Sometimes kids do get bored with it. I've had to recommend that parents make them do that before they get their regular screen time. And that seems to work out really well. So here's some other things that I think are important to look at. We talked about electronic media, sleep, exercise, martial arts, mindfulness, even time in nature is shown to be helpful in ADHD. I'll go over some of these. Sleep's a huge issue for some of these kids. Sometimes they can't fall asleep, sometimes they wake at night. And it's really important to intervene because all of these parents will tell you that their kids are worse if they don't sleep, just right down the line. So you start out with sleep hygiene, and now you have to sometimes hide the electronics. Parents will come in and think that they've taken the electronics away, and there's the kid at 3 o'clock, either on social media or playing video games. Very common. I have a lot of parents who literally have to turn off the internet, lock up the phones, whatever. I think melatonin is very, very helpful. Sometimes there are sleep audios, there's apps you can use, guided imagery. There's a couple of supplements that are helpful for sleep, 5-HTP, which increases serotonin, and L-theanine, which increases GABA, and there's some herbal formulas. So definitely something to really explore in these kids. And then exercise. Exercise, lots of research showing that exercise absolutely is important in ADHD. This systemic review, you can see the results here. And parents will tell you it's crucial for the kid's behavior. So many kids with ADHD don't like team sports. Some of them do, but it's hard for them to pay that much attention. There's too much going on at once. It's hard to organize and be aware of everything going on. Whereas they may do way better in individual sports. And they also don't like sitting around and listening to a coach talk to them, honestly, which is a lot of team sports. So tennis, swimming, and surprisingly, many of them do very well in martial arts. I say surprisingly because you'd think that requires tons of concentration and attention, but they seem to be able to muster it up in the presence of the right teacher. Then there's some kids who won't do anything outside of their house as far as exercise. And what I get the parents to do there is to get a treadmill or an exercise bike and say, you want to do your screens, you ride. And that works great. They can either do their screen while they ride, or they can do their screen after they ride. And that's a very effective way to get these kids exercise. Mindfulness and other kinds of meditation can be helpful. It's actually hard to find good mindfulness groups for kids. But if you can, that can be really good training for them. Some studies have shown that just mindfulness in schools actually helps everybody's attention. And what I would really love to see is mindfulness training in schools. You don't even have to separate out the ADHD child. So how do I treat ADHD? Make sure the diagnosis is correct to start with. Clean up the diet. Elimination diets were indicated and possible. Check serum ferritin, zinc. I also check vitamin D because so many kids are low. Treat with omega-3s, multivitamins if their diet is bad, botanicals sometimes, behavioral interventions. Make sure they're doing exercise. Martial arts is a good one. Mind-body intervention, school modifications, maybe brain training, other complementary and alternative treatments like acupuncture sometimes, and then psychostimulants when I need them. Here's some simple things you can do, even if you don't have an hour. Talk to them about decreasing sugar and processed carbs. Get a nutrition consult if possible. Try a simple elimination diet, even just gluten or casein, if that's all that can be done. Check the labs, begin fish oil, address exercise, sleep, screen time, of course, refer for parenting help where needed. So my final take-home message, let's be careful to not overdiagnose ADHD. And when we do, consider beginning with safe, non-pharmaceutical options before prescribing psychostimulants. Thank you.
Very much. I'm sure there are questions.
Thanks, very helpful. Specifically thinking about the dietary changes, supplements, and checking labs. Do you tend to do those all at the same time, or do you pursue a sequence, order the labs if the diet doesn't work?
Yeah, so I have my initial visits are my consults are 2 visits separated by a few weeks. So what I do is get the history the first time, then I get the labs. And I talk to them during the first part about diet. And then when they come back, I will start the supplements and the dietary changes if it's just good diet. Now, elimination diet, I do that completely. If they're going to do that, I do it when no other interventions are happening because it's really important. I mean, obviously, it's a pain in the neck to have to be off gluten in your whole life. So when we're doing the elimination diet, either I do it first or I do it when they're stable on what other interventions I've done. It's a good question. Yeah.
Thank you very much. I actually did a day with you last year.
Oh, yeah.
Our development curriculum. So I really appreciate this. And a little bit more dive than the half day we got. I do have a question for like the primary care setting. We have 20 minutes and we in our clinic rely mostly on Vanderbilt, which has a GAD-7 and then a PHQ-9 built in. And when people screen positive for more than one diagnosis at a time, sometimes the symptoms overlap and one condition worse than the other. How do you recommend starting treatment if they have co-occurring anxiety and possible attention deficit which do you address first? Do
Oh,
you go for
yeah.
both at the same time?
Good question. I think I try and look at which one seems to be causing more of a problem. Really, like as I told you, try and ask the child if they're old enough, like what's really causing you the problem here. And then a lot of it is, where the problem is. If anxiety is permeating their life and the ADHD is only causing some school problems, well, I'll probably aim at anxiety first. One thing I wanted to say about that, when I first started specializing in ADHD, I was in primary care and I had 20 minutes of patients also. And what I started doing was just bringing them back. Well, I also got permission to have 40 minutes for some of my patients, so that was cool. But I would just start bringing them back. Like I said, okay, if you're in here for ADHD, I'm going to see you 3 times over a couple of week period. And that's that's how I got the time to do this stuff.
There's a number of questions on the Zoom, and I'm going to combine a couple here. One actually is just simply about the brand of omega-3 gummy, as well as any preference regarding either fish oil brand or non-gummy.
I'm okay saying a brand.
You don't have stock in it, I think it's fine.
I have no stock in anything. So Nordic Naturals is one of the most well-known supplement companies for fish oil, and they make a gummy now. It's called Nordic Naturals Ultimate Omega Gummy Chews. And for a gummy, that's the best one. I like Nordic Naturals across the board. They have a teen form that's pretty small pills, but they're expensive. And so I have a whole list of supplements for people who are of lower socioeconomic status. And so, for instance, GNC has the most reasonably priced fish oil if you want a liquid. And I don't know if you all know about Consumer Labs. Consumer Labs is an outfit that checks supplements for quality and cost, and the GNC is approved as that's the right quality. It has what it says it has, doesn't have contaminants. So I will look at cost too.
And then Dr. Maria Gabi actually says, so appreciate this talk, but also says as a job secretary, are you assessing the level of shame a job feels and how to impact the decision?
So the question is the decision to treat, whether you make the decision to treat based on shame and low self-esteem. Yes, it is. I often tell parents and other people, I have 3 criteria for wanting to use psychostimulants. The first is the child can't learn at all. They're just like failing at school, which is not true of lots of kids with ADHD. The second one is they're having real social problems because they have ADHD. And the third one is the family situation is a disaster, real difficulties. All of those fall under the rubric of decreasing self-esteem. And so, yes, I really look at self-esteem. And if that is a problem, I will tend to start psychostimulants earlier.
Just a quick, are you using psychostimulants to cover all medications? Because you haven't spoken about the non-stimulants.
Yeah, I haven't. I know I use non-stimulants are my third line. It's usually sort of the Ritalin family, the Adderall family, and then non-stimulants. I don't find them as effective. I find they have lots of side effects, but some kids who need treatment and who don't tolerate psychostimulants, I will use Strattera or one of the others. Good question.
I'm curious if within your population, there's different backgrounds, like medical history in particular. I help run our high-risk infant follow-up program or our ICM follow-up. And so for our preterms or kids who have had brain injury, do you find that they need a different approach?
I don't think they need a different approach, but I sure see many kids who have brain injury, genetic issues, other developmental issues. And I guess I would say they need a more intense approach, but I still follow the same kind of general approach for them.
I'm curious if any particular part of the regimen that you go through seems to be more or less effective for them. Curious.
I think so. I think it really differs a lot.
We are over time, so I think we're going to end it here. There's one comment on the Q&A that I just want to share with people, that liposomal melatonin officer threat that bypasses first pass metabolism and quicker onset of reduced dose.
And we usually children that make it to the middle of the night, I think, Dr. David Raver, who's part of the office.
Yes, Dr. Traver, thank you.
All right, thank you very much for this great talk.
Thank you for coming. It's a pleasure.